Hello and welcome to the Pediatric Anesthesia Podcast of the Month from Open Anesthesia, where we highlight an interesting image or clinical finding. My name is Debnath Chatterjee and I'm a pediatric anesthesiologist at the Children's Hospital of Colorado. I do not have any financial disclosures. The clinical image for this month is a chest x-ray of a 2-year-old boy after a witnessed choking episode showing hyperinflation of the left lung and mediastinal shift to the right, suggesting an airway foreign body in the left lung. Tracheobronchial foreign body aspiration is a potentially life-threatening event, especially in children less than 2 years of age. In the United States, choking following foreign body aspiration is the leading cause of unintentional injury mortality in infants and the fourth most common cause of unintentional injury mortality in older children. Approximately 80% of pediatric foreign body aspirations occur in children less than 3 years of age, with a peak incidence between 1 and 2 years of age. Toddlers have several predisposing factors. They have a tendency to put objects in their mouth. While they have the fine motor skills to do that, their molars are not well developed to chew food properly. They also have immature swallowing coordination and are easily distracted when eating. Young children are particularly vulnerable to airway obstruction secondary to the smaller airway diameter. In older children, neurological impairment, loss of consciousness, and alcohol or sedative abuse are predisposing factors. Food products such as peanuts, other nuts, sunflower seeds, watermelon seeds, and popcorn are the most commonly aspirated foreign bodies in infants and toddlers. Non-food items such as small toys, coins, paper clips, pins, and pen caps are more commonly aspirated by older children. Toy balloons and inflated gloves are the most common objects in fatal childhood foreign body aspiration. Foreign bodies that are round are more likely to cause complete airway obstruction. In addition, non-compressible objects that don't break apart easily and have smooth, slippery surfaces are more dangerous. Aspirated food products and vegetable substances expand with moisture and may fragment into smaller pieces. Similarly, aspirated oily substances such as nuts can cause chemical pneumonitis. Also, sharp objects may cause trauma to the airway. Let us now discuss the location of aspirated foreign bodies. Most airway foreign bodies are lodged in the mainstem bronchus, right more than left. In a review by Aaron et al., the sites of foreign bodies were as follows: larynx 3%, trachea 13%, right mainstem or distal bronchus 60%, left mainstem or distal bronchus 23%. Foreign bodies that are large and bulky or those with sharp, irregular edges may become lodged in the larynx or upper trachea. The clinical presentation depends upon several factors, including the degree of airway obstruction, the location of the foreign body, age of the child, the size and the composition of the foreign body, and the elapsed time since aspiration. Following an acute choking episode, the foreign body may be coughed out or coughed up and swallowed. If not, the foreign body may cause either partial or complete airway obstruction. More commonly, children with foreign body aspiration present with partial airway obstruction and persistent symptoms. While a witnessed choking episode is highly sensitive for the diagnosis, caregivers may not remember such an episode. The most common symptom is cough followed by tachypnea and stridor, often with focal monophonic wheezing or decreased air entry. Regional variation in aeration is an important clue to the diagnosis. The classic triad of wheezing, coughing, and decreased breath sounds is not universally present. In a review of 135 cases of airway foreign body aspiration in children, The classic triad was present only in 57% of the children. The clinical presentation also depends on the location of the foreign body. Laryngotracheal obstruction is uncommon but is more likely to present as acute respiratory distress heralded by stridor and dyspnea. A child with mainstem obstruction will typically present with coughing and wheezing. Children with foreign bodies in the distal airways may be asymptomatic following an initial choking episode. A child who presents days to weeks after the aspiration event may have clinical evidence of airway infection or inflammation, including fever and pneumonia. The preoperative evaluation of a child with a suspected airway foreign body should begin with a detailed history of the onset and severity of symptoms. Physical examination should include an evaluation of the upper airway as well as auscultation of the lungs for symmetry of breath sounds. Details of any prior anesthetics and relevant comorbidities must also be reviewed. The patient's chest X-ray should be reviewed preoperatively as well. However, a normal chest X-ray does not rule out foreign body aspiration in the setting of concerning clinical symptoms. While radio-opaque objects will be seen on chest X-rays, children typically aspirate radiolucent objects such as food products, which will not be visualized. The characteristic chest X-ray findings include lung hyperinflation, atelectasis, and mediastinal shift away from the affected lung. Delayed presentation of a retained airway foreign body may result in a pulmonary abscess or pneumonia. The management goal for tracheobronchial foreign bodies is removal of the object. Urgency is increased in the setting of laryngotracheal foreign body or the presence of respiratory distress. The procedure of choice is rigid bronchoscopy because it allows control of the airway, visualization, and manipulation of the foreign body. Rarely, a thoracotomy may be necessary if the foreign body can be visualized but cannot be removed by rigid bronchoscopy. After adequate pre-oxygenation with 100% oxygen, either an inhalational or an IV induction may be performed. In addition to standard ASA monitors, adequate intravenous access must be obtained. Following induction of general anesthesia, direct laryngoscopy is performed and the airway is topicalized with local anesthetic. The operating room table is then rotated 90 degrees away from the anesthesiologist. Close communication between the anesthesiologist and surgeon about the status of the airway is critical throughout the procedure. The surgeon performs a direct laryngoscopy and the trachea is intubated with a ventilating bronchoscope. The anesthesia circuit is attached to the side port of the bronchoscope to insufflate oxygen. The bronchoscope is then advanced into the distal airway under direct vision. If necessary, airway secretions are gently suctioned. Once the foreign body has been visualized, an optical grasping forceps is inserted and the foreign body is gently grasped. Every attempt is made to remove the foreign body in one piece. After the foreign body has been successfully removed, a follow-up bronchoscopy is performed to rule out the presence of additional foreign bodies. The patient is then allowed to emerge from anesthesia with a natural airway or after endotracheal intubation. This patient had some kind of a nut dislodged in his left mainstem bronchus and 3 small pieces were removed successfully. One of the most critical moments during foreign body removal is passage through the laryngeal inlet. If the foreign body is accidentally dislodged in the subglottic region, it may cause complete airway obstruction. In that case, it must be pushed distally from the trachea to a mainstem bronchus to allow ventilation of the opposite lung. There are 2 broad approaches to the mode of ventilation: spontaneous versus controlled ventilation. The choice between spontaneous and controlled ventilation is based upon the personal preference of the anesthesiologist and the surgeon. In a review by Littman et al., the mode of ventilation used did not influence the occurrence of adverse effects. In the spontaneous ventilation technique, general anesthesia is maintained with either volatile anesthetic agents or total intravenous anesthesia with a propofol and/or remifentanil infusions. In the controlled ventilation technique, after adequate pre-oxygenation, general anesthesia is induced with propofol and succinylcholine. Intermittent positive pressure breaths are then administered through the side port of the bronchoscope. There are advantages and disadvantages of both spontaneous and controlled ventilation. Maintaining spontaneous ventilation during general anesthesia will ensure that there are no interruptions in the child's own respirations. With obstructive lesions, negative pressure breaths may result in a better gas flow and ventilation perfusion matching. A child breathing spontaneously will also be able to self-regulate his or her anesthetic depth. There is also a decreased chance of dislodging the foreign body with positive pressure ventilation. However, with spontaneous ventilation, full stomach precautions are ignored. If volatile anesthetic agents are used, often high inspired concentrations are necessary. There is also the potential for coughing from light anesthesia, which increases the risk of dislodging the foreign body or causing tracheal damage. Controlled ventilation, on the other hand, ensures airway immobilization and decreases the risk of coughing. There is better control of anesthetic depth and more rapid emergence from anesthesia. There is also a decreased risk of aspiration in a patient with a full stomach. However, controlled ventilation eliminates the child's own respirations, which may result in faster oxygen desaturation. There is also the theoretical risk of dislodging the foreign body distally, worsening air exchange and creating a ball valve effect. With controlled ventilation, it is important to allow adequate exhalation time and avoid air trapping due to stacked breaths. In summary, tracheobronchial foreign body aspiration is a potentially life-threatening event, especially in children less than 2 years of age. A variety of food products and non-food items are commonly aspirated by toddlers and infants. Early recognition and a high index of suspicion is critical. The preoperative evaluation should include a detailed history and a focused physical examination looking for the symmetry of breath sounds. The classic chest X-ray finding is lung hyperinflation and mediastinal shift away from the affected side. The procedure of choice is rigid bronchoscopy for removal of the airway foreign body. Close communication between the anesthesiologist and surgeon about the status of the airway is critical throughout the procedure. Thank you for watching this podcast.